We left off yesterday, or with part one, with the fact that we've got fluid entering into the lungs along with a bunch of inflammatory response cells. The neutrophils are going crazy in there. It's even leaking blood. The capillaries have become so porous that proteins are leaking out. And remember, water follows proteins. Remember that. Those big molecules, those big protein molecules attract more water, making it very difficult to get them back out and into where they need to go. So this slide shows you what a normal alveolar unit should look like. And here is our ARDS unit filled with really gross stuff that's getting in the way of our ability to diffuse gas. And remember, because CO2 is a little more diffusible, or a lot more diffusible than oxygen, oxygen is really affected dramatically. So we talked about our two kinds of pulmonary edema. We had our hydrostatic pulmonary edema and non-hydrostatic. The hydrostatic pulmonary edema was the one that's the fluid shift, the transitive, the CHF model. The non-hydrostatic pulmonary edema is this fluid that's coming in here, going to wreak havoc on the alveolar walls, and that is our ARDS pattern. It's going to cause a restrictive physiology, so this is a restrictive disorder, and it reduces our lung compliance. The lung is not compliant. It doesn't move. The chest, the lungs do not expand easily. The compliance is reduced. And also they have what's called refractory hypoxemia. And we've seen this in some other diseases. Do you remember? This was also present in our pulmonary emboli patients because you give them oxygen and nothing happens. So it's a different reason, but the same thing happens to these people also. You'll see an increased work of breathing, and then it's also going to impair your ability, the patient's ability to produce surfactant, and therefore, what does surfactant do? It stabilizes our alveoli, right? It keeps them open and reduces the surface tension. So without it, the little bubbles that are our alveoli, they want to collapse. So now they're filled with fluid and they want to collapse, further hindering the ability for them to exchange gas. So normally the pulmonary arteries will be carrying good, blood flow to normal lungs, but when your alveoli start to fill with fluid and they no longer have oxygen going into them, that causes a vasoconstriction in that area. So as you recall from many of our patients, they develop this constriction in their pulmonary vasculature. And so that shunts the blood away from those areas and increases their resistance, right? The pulmonary vascular resistance. So they also get a vasoconstrictive response. Okay, so here's a question for you. If a person has refractory hypoxemia, what happens to the PO2 when the FiO2 is increased? Will it decrease? Will it stay the same? Or will it increase? So let's look at the question again. If a person has refractory hypoxemia, what happens to his PO2, so his arterial blood oxygen, when I turn up the FiO2? So if you answered stays the same, then you would be correct. So that is the definition of refractory hypoxemia, is that even when you increase the FiO2, the PaO2 does not increase as you would expect it. So ARDS, let's give it a definition. We do have two definitions, and those are in your book. They are listed on page 594. And we have two, the American European Consensus, which has 5 basic components. It looks at the fact that the patient has a reduced lung compliance, so their lungs are becoming stiff. They have a hypoxemia with a PaO2 to FiO2 ratio of less than 200. So that's the P, it should be the little a, but the slide capitalized it, wouldn't let me go little. But I'm talking the arterial oxygen divided by the FiO2. And we'll take a look at that in a couple slides here. If it is less than 200, then that is bad. And by the American European Consensus, you have ARDS, along with the bilateral infiltrates on the chest x-ray. And you had to have some type of acute illness, a trigger for this ARDS. And also, no evidence of congestive heart failure, because this goes back to the beginning when we looked at the ways you can get pulmonary edema. So, in other words, they have to rule it out. You have to rule out the fact that it is a congestive heart failure problem that the patient is having before you can say that this patient has ARDS. So now we have another definition. This is the Berlin definition, and it primarily rests on this factor, these PF ratios. Let's look at these PaO2s. I couldn't, again, put the little a. It just did not let that happen. But these are arterial oxygen divided by your FiO2. So as you see here, the FiO2 is changing, and this is different FiO2s, which this one's room air, 35%, 50%, and 100%. Here's the patient's arterial blood oxygen, the P(a)O2 of 80. Is 80 normal? Yes, right? 80 to 100 is considered normal. So the first one that I took here was normal, right? Here's 80 to 100, which 80 is normal. And there's room air. That's normal, because all of us are breathing room air. If you divide 80 by 0.21, you get 380. Well, sure enough, the normal level is anything greater than 300. So this patient is fine, right? And he should be. So this brings to another thing that I want you to always remember, is if you come across a formula or a value and you don't remember whether it's normal or not normal, but you remember the formula, plug normal numbers into it and see what you get, because normal equals normal any way you slice it. So you see, I put normal numbers in here, and now I know that this is normal. Okay, now let's look at this patient who is on 35% oxygen. And when you take 80 divided by 0.35, you get 228, and this would come into the mild range. So according to the Berlin definition, 300 to 201 is considered mild ARDS. Now, if you look at the AECC model, then that area, they consider this to be somebody who has acute lung injury. They don't go as far as to say, call this ARDS yet. So they reserve ARDS for these two categories. When it approaches these levels, then they say, okay, now we'll say you have ARDS. But this Berlin definition is very popular because it's very easy to remember. And so we have our 200 to 300 being mild, and 101 to 200 being moderate, and anything less than or equal to 100 is definitely severe. So let's look at this patient. So the patient's PaO2 is still 80, okay? And you'd say, well, 80 is normal. But look what it took to get there, 100% oxygen, okay? So it's all relative, right? Because this guy has severe ARDS. Okay. So there's some key features that differentiate these two definitions. And as I had pointed out, they are in that table in your textbook. But the AECC definition does give you that acute lung injury component of their when they look at the PF ratios. And then you have to exclude this heart failure thing. So that's what they're talking about here. They want to look and see if you can estimate what's happening to the left side of the heart. We talked a lot about that in part 1. That is going to be a key component of whether somebody has congestive heart failure or not, is knowing how these left-sided pressures are. Because we know that a lot of things cause right-sided problems, right? We learned all of our lung diseases. Anything that happens to the lung, pretty much, we're going to see it in that right ventricle and that right atrium. But when there's something actually happening to the whole heart, that is heart failure. And so we've got to look past anything that could be the lungs could be affecting. So that would be the right side. And we've got to get to that left side and see if it is affected also. So it's saying here that you could use an echo to do that. And we also have ways to put catheters in to measure some parameters that give us ideas of what the pressures in the left side of the heart are doing. And so that's what this is saying. We need to know that this is not congestive heart failure. We need to know that all this pulmonary edema, all this fluid that I'm seeing on this x-ray, because remember, both of them are going to have bilateral infiltrates or opacities. And so they need to see which is it? Is it your heart or is it your lungs? So the key component to that is to know what's going on the left side of the heart. And so remember also that the other thing on the chest x-ray that we saw is that the heart is enlarged with a person with CHF versus a person with ARDS. It would not necessarily or would not be enlarged. But they're both going to have those bilateral infiltrates. They're both going to show signs of pulmonary edema. So also the other thing is that one thing we do know about congestive heart failure is that it tends to be this slow onset of gradually getting worse and worse and worse, because the heart's going to compensate for its lack of ability to pump properly. And so it's going to come on, although the patient may finally get to the point where they can't tolerate it and the body can't compensate, and they may go downhill at that point, it is something that happens over time, and more so than somebody who has ARDS. So what it does for us is you have to see that there are similarities, again, in these two diseases. So they both are going to be anxious and dyspneic and have tachypnea. They both have decreased compliance and reduced lung volumes. They both have severe hypoxemia and may require a ventilator.